Okay. A very good evening, sir, and all the audience. I am pleased to inform you that we are going to do latest update in the management of overactive bladder with a very renowned urologist of Allahabad, Dr. Mohammad Arshad, sir. Sir, you're most welcome in this session.
Thank you. Okay. Good evening, everyone. Master Dr. Assistant Professor in Department of General Surgery in Mirzapur Medical College. And today I'll be talking on management of overactive bladder or storage issue in lower urinary tract symptoms. Coming to the lower urinary tract symptom, it includes three things. One thing is storage symptoms, voiding symptoms, and post-menstruation symptoms. The storage symptoms mostly include frequency, urgency, urge incontinence, or nocturia. In between four these things, the most important and more bothersome for the patient is the urgency and urge incontinence. And it has been seen that these two things out of these four storage symptoms, the urge incontinence and urge urgency, they causes most bother health related quality of life, which decreases its quality of life. And it has been seen that the storage symptom, that is the overactive bladder. There are many types of overactive bladder, but in a broad way, it is defined as a dry type or a wet type. Dry type includes when there is no urge incontinence, while in the overactive bladder with a wet type, associated with urge incontinence. So the basic these two types is that incontinence is present in the wet type and this in dry type, urge incontinence is absent. So the this is the mostly the overactive bladder. You can change the slide now. And so coming to there are various etiology and various factors associated with the overactive bladder syndrome. Actually, it's a syndrome, not a disease, because it has got the multiple symptoms. On that basis, it's called a syndrome. So there are many associated factors with this this lower intake symptom, which include this overweight, smoking, and various other overweight, smoking, and the daily lifestyle, and other things are there. So on that basis, there was a study conducted by this one Chinese urologist. They found that the person who are a smoker or they are ex-smoker, the frequency of overactive symptom or the storage symptoms is more in the person who are current smoker or the ex-smoker, and the quality of life this decreases with the smoking or the person who are ex-smoker. You can change the slide now. Vijayji, you can change the slide. And the same this worker, they have found that the person who are ex-smoker or a non-smoker or a smoker, they found that the person who are current smoker or the ex-smoker, the various overactive bladder or the storage symptoms are more in this current smoker when followed by the ex-smoker, and they were when it was compared with the non-smoker. They found that the frequency is around 1.3 times more, nocturia is around 1.5 times more, urge incontinence was 1.5 times more. Overall overactive bladder syndrome was 1.5 to 4.5 times more in the smoker and the ex-smoker group. So it was clearly this smoking was associated with poor quality of life in the person who are smoking. You can change the slide. And when giving the treatment, the first line of treatment for the person who was suffering from the overactive bladder, is that this lifestyle modification, which include weight loss or stop smoking, avoiding this irritant foods. These are the fact things which should be used to decrease the symptoms of the overactive bladder. But when coming the second line treatment is the pharma drug, and it was seen that the person who the first line drug is anticholinergic, and we basically use the solifenacin, darifenacin, and the tolterodine for the management of overactive bladder. But the problem with the anticholinergic drugs is that with its use with time around after 2 to 3 months, most of the patients, around 90% of the patients, they leave the drug because the most common symptoms they are associated with the dementia, and with increasing age, this problem create more. It's a vicious cycle. Create more problem in the person who are suffering from the this storage symptoms. So a new drug was for because of these symptoms, a new drug was launched, which was the Mirabegron, and it's a beta three selective beta three adrenergic receptor, which act only specifically on the beta three receptor, and it was seen that this drug Mirabegron was having very less dry mouth or constipation, because they don't act on the cholinergic receptor. So the symptoms of dry mouth and constipation was very much less compared to the anticholinergic drug. But and the overall quality of life was almost equal in the patients who are taking the anticholinergic or the Mirabegron. But the absolute contraindication for the Mirabegron was because of it cannot be given in the hypertensive group patient who are having uncontrolled hypertension. So this drug should be avoided. But all of the safety of Mirabegron is very good compared to the anticholinergic. And so many of the urologists in present day, they are promoting Mirabegron as a first line treatment in compared to the anticholinergic drug. You can change the slide. And when Mirabegron was given in the person who was suffering from the overactive bladder, along with the bladder outlet obstruction, mostly in the male, it was seen that when tamsulosin was added with the Mirabegron, the micturition in number of micturition per in 24 hours and mean voided volume per micturition was more in Mirabegron compared to the anticholinergic drug. So overall, it was seen the quality of life improves with the addition of the tamsulosin and Mirabegron. The person is suffering from the overactive bladder with bladder outlet obstruction. You can change the slide. It was along with this quality of life. It was seen that when the person was taking Mirabegron or they were taking the anticholinergic, the overall quality of life was the symptoms was almost equal when compared to the anticholinergic. But the side effect, because of which the drug was patient was leaving the anticholinergic drug, was more in the person who was taking anticholinergic, and was less what in the person who was taking the Mirabegron. So the drug leaving effect was less in Mirabegron group. Coming to the this after the management of the patient fail with the treatment with the pharma drug, then the third line of management comes the interventional group. Intervention in the form of this either the onabotulinum toxin or with the sacral nerve stimulation, or the various other tibial nerve stimulation is also given for the management. And when it was the study was in the recent 2021 study, when it was seen that the overall the side this efficacy was almost equal in the over this the person who were taking the onabotulinum toxin or the person who were following the sacral nerve modulation therapy. So the side with this overall efficacy was almost equal, but the problem with the botulinum toxin was that the person who were taking the botulinum toxin, they were having the more symptoms of acute urinary retention more symptoms of dysuria, more symptoms of this UTI were more common in the person who were taking the botulinum toxin. But and the problem with the botulinum toxin was that the side this efficacy wean off after around 6 months of treatment, and then some person they complain the same problem even after the 3 months of treatment. So the problem this was the problem. Overall, otherwise the onabotulinum toxin was having a very good side profile in the management of refractive overactive bladder. Yeah, we can change the slide. This is how I explained this thing. You can change it. Vijayji, you can change the slide. They have seen the same thing. They have seen. They are saying the safety of onabotulinum toxin is better. This almost they both have the same safety profile, but the side effect was slightly more. The acute side effect was slightly more in the body, for in the person who were taking the onabotulinum toxin. And there were others. There were studies in which the method of giving the onabotulinum toxin was also compared, either giving the lignocone, giving the just local xylocaine or the lignocaine, followed by the this onabotulinum toxin this injection, around 20 ml of this onabotulinum toxin, 20 ml of onabotulinum, 20 ml diluted in our 300 units of onabotulinum toxin, diluted in around 300 ml of saline. We injected at 30 place of the 30 place in the bladder. Their other method is they leave the trigone, and in some person they also include the giving the injection at the trigone side also. So when it was compared, the efficacy was almost equal. But some person also they uh, studied giving the this botulinum toxin along with the alkaline this solution of bicarbonate. When it was seen that the alkaline solution with the botulinum toxin, the efficacy was more, and the person compliance was more in the person who were given with the alkaline this like lignocaine. The compliance was more in that group. You can change the slide now. It's the same. This study was conducted by this Chinese group. They have seen that this they have done a double-blinded randomized trial compared to protocol of local anesthesia with this botulinum toxin A, and they found that the alkalinized lignocaine solution, they were having the more better safety profile and the compliance in the person who were given this protocol A compared to the person who were given the protocol B. And change the slide. So the same thing what I told that when this was compared, it was seen that the overall side this safety profile and the compliance was better in the person who were given the protocol A, that the bicarbonate lignocaine solution along with the bonta, compared to the this protocol B, in which the saline was given with the xylocaine along with the bonta solution. Compared to this lower neurotract symptom, they have also it is basically seen in the adult group of the patient, and in elderly the most they are also in the adult group. We have seen that they are suffering from the diabetes mellitus, hyperlipidemia, hypertension group, and all these comorbid disease, they are associated with endothelial dysfunction, which causes decreased blood flow, causing the ischemia of the bladder urothelium, which result to the abnormal activation of the afferent nervous system of the bladder, thereby increasing the chance of this lower urinary tract symptoms in the person suffering from in this older age group. So there was a study in which they have seen the effect of various treatment modalities, just like for diabetes, this hyperlipidemia. They have given the statin for the hypertension group. They have given the androgen and alpha receptor ACE receptor blocker, and this they have seen in the person who were taking these medications, the storage symptom also decreases in the person who were taking these medications compared to the person who was suffering from this disease and were not taking the medication. So it was this there was a this some correlation exists between these comorbidities along with the lower unit tract symptoms, and mostly in male. You can change the slide. This is the same thing what I told. This statin, it reduces the risk of this overactive bladder outlet obstruction symptom, and it was significant in the 60 years of 60 years of age group, and it slowed down the progression of LUTS in patients taking statin for more than 1 year. And otherwise, this IPC score was better in the person of hypertension who were taking the ACE receptor blocker compared to the person who were not taking any medication for the hypertension. And this person suffering from the lower unit tract symptom, they were having more chance of fibrillation and compared to the person who were not having any bladder outlet obstruction. So it was clearly seen that the person suffering from the dyslipidemia or the hypertension, and if they are taking the medication for these comorbidities, then the symptoms of lower unit tract symptom decreases, while the person who were not taking these medications, they were suffering, they were tend to have more chance and severe lower unit tract symptoms. And this pelvic floor exercise, actually, this should be the first modality in the management of the overactive bladder, along with this reducing all this lifestyle modification, this avoiding the irritant, and this avoiding the caffeine food, or this coffee, etc. This it should be the first line of treatment. And there was a study in which this Norwegian study in which they have found the person who were doing this pelvic floor exercise and before antenatally, and they have found that the person who were doing this pelvic floor exercise along with the biofeedback, this should be noted that pelvic floor alone does not decreases the chance of overactive symptoms, or did not decrease the severity of overactive symptoms, but pelvic floor training along with the biofeed mechanism, along with the electric stimulation of the bladder. These, when it was combined with other modalities, the chance of the urinary incontinence decreases. But alone, the recent studies say that the alone pelvic floor muscle training does not decrease the urinary incontinence in most of the patients. But it should be followed. The person suffering from the pelvic floor, this overactive bladder syndrome, they should do a pelvic floor muscle training. Along with this overactive bladder symptom, it also improves the pelvic floor muscle tone, which prevent the persons, this females, in mostly in the female, this other symptoms of this pelvic symptom. So this should be done, but but for overactive bladder syndrome, it should be done along with the biofeedback mechanism, which includes this double avoiding, or the person should be uh, timely avoiding and double avoiding, or there should be electric bell system is there, along which the person should avoid, and this should be the biofeedback mechanism, and there's other modalities also which should be included. Next. Same thing in men, non-invasive treatment of urinary incontinence secondary to radical prostatectomy. Pelvic floor muscle training should be given, but along with the and it includes because it increases the pelvic tone. The pelvic tone increases, the chance of decreasing the incontinence is also decreases. But it's better to give along with the biofeedback pelvic floor electric stimulation than using pelvic floor muscle alone. So pelvic floor muscle training should be done along with the biofeedback mechanism to increase the more benefit. And most this the in the postmenopausal age group, the patient because of this estrogen deficiencies are there, the various hormonal deficiencies are there. Then because of that, it leads to the atrophic urethritis. This atrophic urethritis causes the symptoms of this urgency and urge incontinence, but mostly the patient the symptoms of urge incontinence. So, health professionals should consider urinary incontinence a clinical priority and develop appropriate diagnostic skill. It was this recommendation by the EMRs, European Menopause and Andropause Society. They should be able to identify and manage any relevant modification factor that could alleviate the symptom. Just like the patient is having estrogen deficiency, then the patient should be given this estrogen cream. Or if the patient is suffering from UTI, this should be managed. If the patient is having some other comorbid disease, this should be managed. If the patient is having the bladder stone or this cycle calculus, this should be managed to decrease the severity of the symptoms. And change the slide. Next, this estrogen and other pharmacological interventions are helpful in the treatment of urge incontinence that does not respond to conservative management measures. This is a treatment for the menopausal, post-menopausal age group, but the overall efficacy with the estrogen cream, and that too it should be given locally applied and not with this oral drug should not be given, but it should be locally applied to increase the efficacy of the drug. And third line of therapy like sacral nerve modulation or intravesical onabotulinum toxin or a tibial nerve stimulation are helpful in selected group of patients, just like patients suffering from the idiopathic overactive bladder or the person suffering from the neurogenic overactive bladder. So in that patient, this interventional therapy is useful. Otherwise, it should not be given as a first line modality for the management of this overactive symptoms. Next. The last group of management include the surgery. Surgery per se does not have a very good effect on the quality of life, this overall symptoms of the urinary incontinence, but it should be given if the person is suffering from the stress urinary incontinence or the patient suffering from mixed urinary incontinence. That is, patient is having symptoms of overactive bladder along with the stress urinary incontinence. In that group of the patient, the mid-urethral sling or the transobturator sling or this modality of surgery can be given. And the person suffering from the overactive bladder itself, this myomectomy or detrusor muscle myomectomy can be given, or the psychoplasty can be done. But the overall this result is not very good. So because of that thing only, this is the last modality. Coming to the highlight of this presentation, the epidemiological studies finding this suggests that the current and the ex-smoker, they have the increased risk of symptoms, and this is more pronounced in the young age group. Anticholinergic drug increase the risk of dementia. So it should be very carefully selected in a selected group of patients only. Anticholinergic drug should be given, and it should not be given in the person suffering from the dementia. Next, coming to the management, Mirabegron is a monotherapy or as an add-on therapy along with the tamsulosin or the solifenacin has demonstrated efficacy and safety in management of symptoms of overactive bladder. Aquablation itself does not come in the management of the overactive bladder symptom, but it is done the person suffering from the BPH, and along with that, it is done along with the special instrument is there, along with the which is done along with the truss. In that condition, in that condition, it is done in the BPH. Otherwise, it's not done itself for the overactive bladder itself. Spectral stimulation is better therapy option in the onabotulinum toxin injection in the refractory overactive treatment. And the comorbidity treatment, it has been seen in the comorbidity treated, the person suffering from the comorbidity decreases the risk of this overactive symptom. And addition of guided program along with the pelvic floor muscle exercise can improve the continence recovery rate. This is EMS guideline. They suggest that the healthcare they should know what they are treating, and successful treatment of overactive bladder syndrome depend upon the accurate diagnosis, along with the treating the cause of this contributing factor for the overactive symptom, and also treating the comorbid disease which is present. And the effective and personalized care should be given for the overactive bladder management to increase the efficacy.
Thank you, sir. Now all the slides has been covered. There is a question in chat box.
Okay, let me see. Definitely, this AK Mishra.
It is visible to you, sir, in chat box. Are you? Can you see in chat box?
I can see in the chat box.
There is two questions are there, sir.
Mishra, the latest update in the management of overactive bladder exercise is helpful in overactive bladder patients. Yes, definitely, I told that exercise definitely helps. Not the exercise, but the pelvic floor exercise, and along with this biofeedback mechanism, it increases the overall the safety, this efficacy of in the management of overactive bladder syndrome. So definitely, it helpful. And coming to the food, what should be avoided in overactive bladder in food and beverage. I told that the caffeine, that the patient should be given a bladder diary, which in that bladder diary, it should be noted that the fluid should be restricted, and along with this irritant food, just like spicy, and the other thing is that this caffeinated beverage or this cold drink, this all increases the risk of this more chance of this symptoms of overactive bladder.
And second question is there, sir.
It should be done in a patient of reproductive age, women with overactive bladder. Definitely, just like I told to this protocol is there. The first thing is the patient should, if the patient is obese, the patient should lose weight. Patient should do this pelvic floor exercise. They should manage their fluid intake. They should manage their this food intake, what they're eating. It's like they should avoid taking the spicy food or
Right.
all this the burger, this chow mein, and everything like this. This chaat, chatpada, this all thing. Na, they should avoid eating this thing. They should decrease the intake of coffee. They should decrease the intake of this tea and all, cold drink. These are all irritant. and these all irritants, they stimulate the this scene of fiber in the bladder, which causes the more symptoms of this overactive symptoms.
Thank you so much, sir, for your nice presentation, sir. And once again, thank you, audience who has joined here, sir. Now session is over, I think. Hello.